on into the slides to the fine print. I'm not a fine print kind of guy on phase 1. I'm a fine print kind of guy on phase 2, and I wrote your phase 2 test, but I expect you to know it after the end of dermatology rotation a little bit more than you know it right now. So before we do the review, I wanted to show you guys a couple of things. I mentioned when we were talking about steroid lectures, to get yourself a little chart and have a hard time memorizing them. It was a big, giant, long list. Here's one I got from a drug rep that goes, and shows you like low to high steroids that you can pick out if you're a chart kind of person. Put it in your pocket kind of thing. We got to looking at this, and lo and behold, all these different steroids on this chart are manufactured by the people that gave me this card. So it only lists 4 low potency steroids when there's probably 100 of them. So I think what those guys are trying to do was get me to prescribe their medicine so they can make some money. So when you get things from drug reps like pencils and Post-it notes or charts or stuff like that, there's probably something like that behind it. The one thing that is good that didn't come from a drug rep, and I don't know if you like little books. I'm a little book kind of person. Put it in your pocket. If you got your little white coat, you can slide it in your peripheral brain over here. Any of you guys heard of a Terrascon pocket pharmacopoeia?
Yeah.
You know these? All right, I'll tell you what it is. This is all your drugs you kind of need to know. Dosages, and it's broke down by whatever you're looking at. So dermatology's got a section for all the dermatology drugs. It's got a section for all the OB drugs. It's got a section for all the antibiotics. It's got a section for all, all the asthma drugs. It has a section for all those different things. And what's cool about it is if you go through here, it has little charts. So if you want to know like all the peds doses based on weight, it has a chart in there and just look at it and you just pick out the one you want to give and bit, bam, boom. If you know the kid's weight, gives you the thing, you don't have to do any math in your head. Of course, you probably have little electronic devices that do that now, but if you're a little book person, you can get one of these. And it goes through, it has a steroid chart, it has all different kinds of charts in here. Like when you do your OB rotation, you're trying to remember how to do a pelvic exam, or you're trying to remember what they had to do on a 6-week postpartum exam. It's got it in here and everything. It's not a procedure book. There are little books for that too. But this is mainly drugs. And I used it all the time. I don't use it now anymore. But when I was a student and when I was practicing primary care, especially when I'm seeing people, when you specialize in something, why do you think people specialize? You don't have to remember all this shit. That's one of the, besides you make more money, you don't have to remember all the OB stuff or all the P stuff. But au contraire, and the military's infinite wisdom, you can specialize in something and poof, you need to go see peds today. Or you need to go do pap smears all day long. And you've been seeing dermatology people for months. Well, you need something because you're not going to, you might think you're going to remember it. You might think you're the smartest thing in there, but you probably don't. So get your little peripheral brains. They got little books like this for every rotation you'll go through. I'll pass it around if you want to look at it. And then we'll, you don't have to look at it if you don't want to. And in fact, as far as this review goes, you guys don't have to stay for this if you don't want to. You can record it, you don't have to record it. You can go get a hamburger, whatever you want to do. Okay? This isn't a 50-point review. This isn't a 50-question type review. This is a review on everything we've already talked about. So it's going to be kind of heinous. It's going to be kind of heinous for about 30 minutes. Because I want to go through some stuff. Okay? We want to go through some stuff. Got it all right here. I'll leave it over here when I leave. Okay? All right. So what do I want you to know about anatomy in dermatology? I want you to know about epidermis, the dermis, and subcute. Just those 3 layers. Because if you know those 3 layers, and you know the conditions that we've talked about and where they are in those 3 layers, it'll help you come up with a differential. It'll help you narrow down what you think it may or may not be. That's what's important about dermatology, is knowing where the blood vessels are, knowing what's in the epidermis. You don't have to remember the 6 different layers of the epidermis. You know, in phase 2, you need to know it and everything, but here, phase 1, you don't. I just want you to know epidermis, dermis, subcutaneous. As far as PE goes, physical exams, total body skin exams, that's what you need to start out with, head to toe on your initial exam. Everybody gets naked. You'll go through your dermatology rotation. You may or may not do that. When you're practicing in dermatology someday, that's the way you always start out. Even though they came in for the bump on their arm, check everything out. Tests that you need to remember in dermatology, tests that we do KOHs, we do biopsies. There's different types of biopsies, which you'll have a whole class on for your 3rd test, shade, punch, excisional. You don't have to remember that yet, but we do biopsies. Woods lamp, we do labs. You know, just like everybody else, we draw labs. Topical steroids, this is what everybody's freaking out about. Know the difference between class 1, class 2, class 3, class 7. You know, class 1 is that weak or strong? That's strong. Class 7 is weak. So is class 2 weak or strong? It's strong. Is class 6 weak or strong? It's weak. So if you get down to 3, 4, 5s, that's not weak and not strong. It's kind of mid-range. That's all I really want you to know about strengths for steroids. I want you to know the different vehicles that they're administered with, like creams, gels, foams, ointments, and where they're most appropriate to use them. You know, like psoriasis, you would need maybe a gel so it could penetrate deeper. Foam maybe for the hair. Cream can be used almost anywhere. This is most cosmetically appropriate and effective, but usually it's very low strength. Okay, that's what I want you to know about vehicles. Applications, fingertip units. Guys are freaking out about fingertip units. And you see all that, and what's a hand unit, and what's a hand area, and what's this, and what's the rule of 9s, and what's the body surface area. It's scary stuff. What I want you to know for the exam is fingertip units, grams. How many grams are in a fingertip unit? What's not a whole gram in a fingertip unit? So if they gave you 20 grams of ointment, how many fingertip units are that? That's the kind of stuff I want you to know. Because I need you to be able to figure out in a gestalt kind of way, not for the exam. What I want you to know is that you need to be able to prescribe either a 15-gram tube or a 30-gram tube or a 60-gram tube or a pound jar for the condition that they have, literally. I prescribe pound jars of triamcinolone for stasis dermatitis because they have to put it on their legs twice a day for a week, and it's a big area. So you can prescribe steroids in a pound jar. But it starts out with knowing what a fingertip unit is and how many grams are in a fingertip unit. So that's all I want you to know right now. Grams, fingertip units. The rest is for the rest of your life. All right. Adverse reactions for steroids. So it can be like atrophy, telangiectasias, striae. Just know some of the adverse reactions for steroids. All right, that's it. Some of the presentation. So I'm going to go down all these conditions. There's a bunch of them from all these lectures. I want you to know what it looks like, but you're not going to be asked, somebody asked me today, is there going to be a picture and you want to know what it is? No. I'm not going to have a picture up there and give you a question. What's that picture? I'm not going to do that on this exam. But there's like 50% of the questions have pictures. That picture should help you come up with the answer if you just don't freaking know. You know, for whatever reason, you just got a brain fart and you just don't know. right now what the hell it is. That picture might be the one thing that gives you the clue. What I'm gonna tell you from the rest of these things is maybe a few words with each thing associated with it that might give you the clue. I'm not gonna give you the whole vignette or anything, but I might give you a word or two that might give you a clue along with the picture. But all the questions don't have pictures, and there's no questions that just have a picture. There are questions that just have one sentence. This is an example of a primary lesion, something like that. And you'll see a list of 5 different things down there. You need to be able to pick out which one is a primary lesion or a secondary lesion or a special lesion. Okay, you need to be able to do that. So, speaking of that, macule, papule, patches, and plaques. Those are names not necessarily associated with a condition, but those are all primary lesions the way you would describe them, whether it's a macule, papule, patch, or a plaque. Know which ones are flat, which ones are elevated, and the size. They're all primary, so if you see a macule as a choice, that's primary lesion. But I want you to know which ones are elevated, which ones are flat. There's only 4. 2 of them are elevated, 2 of them are flat, 2 of them are small, 2 of them are large, and know the size associated with them. That should narrow that down for you, because there probably is a question on the exam about that. Macule, papule, patch, and plaque. All right, dyshydrotic eczema. The other name for this is Pemphigox. That's the tapioca type colored vesicles that are usually on the sides of the fingers and the toes. It really itches really bad as they start to dry up. They start to crack and fissure. What would be the initial treatment for that? A strong steroid, topical steroids. So the questions are going to be, you see a picture of dyshydrotic eczema, what's the treatment for it? Yes? Oh, thought you were getting ready to tackle me or something. All right. Know what things look like I said, no treatments. All right, acidotic eczema, that's that stuff that looks like alligator skin. Usually eczema craquelé is like really dry skin starting to crack. If you see something it usually happens the same time during the year. So if you see something in the vignette that says it happens in the winter itchy, that would probably be eczema craquelé. If you see a picture with that also, it looks kind of like cracked skin. It's the winter itch. Nummular eczema. Nummular is another name for coin-shaped or discoid or round spots. Normally, remember I told you about the old man like me who gets at the same place every year and they think that you're a kook, you're malpracticing them, and that nummular eczema pops up. It can coalesce into large plaques. What would you treat that with? A really high dose steroid because it itches really bad. Okay? Nummular eczema. Lichen simplex chronicus. It can be a primary or secondary type lesion. Normally something else is happening, like sebderm or atopic dermatitis that you're scratching the hell out of, and it becomes thick. Lichen simplex chronicus is a thickened skin because you're rubbing it or scratching it over a long period of time. So how would you treat that? High dose steroid. Would you put a cream or a gel on it or an ointment? Probably an ointment or something like that. Cream, yeah, you could, but it's not necessarily going to penetrate as deep as you want. And this is something you might want to use occlusion with too. Okay? All right, stasis dermatitis. That's the one I told you I would prescribe. I'm not going to ask you to, but prescribe a gallon or a whole tub of triamcinolone. That is usually a vascular problem, lower extremities. It itches a whole lot, gets real dry, can form ulcers. You just basically treat that with warm compresses, warm moist compresses with topical steroids. Just know what it looks like. Stasis dermatitis. Stasis is attributing the blood's not circulating. It's in a stasis type place. Atopic derm. If you see in a vignette that it's the itch that rashes, it might describe a little kid that they were itching all of a sudden and then for a week or two and then the rash pops up. It's the itch that rashes. So where's atopic dermatitis usually pop up on kids? Normally on the face, young kids, 2, 3, 4 years old. Adolescents or adults, usually antecubital fossa, popliteal fossa, usually here. It's a moisture problem, so you treat it with moisture and then low dose topical steroids. Remember the little bumps on the side of your arm I was telling you about? That's a variant of atopic dermatitis called keratosis pilaris. Know that. It's a variant of atopic dermatitis. It's not the itch that rashes. It's just a variant of atopic dermatitis. Okay? Irritant dermatitis, know the difference between irritant dermatitis and allergic contact dermatitis. Know the difference between the two. You can have an irritant dermatitis because you come in contact with something, but it's not an allergic reaction. Allergic contact dermatitis, you're having an allergic reaction to something you came into contact with. There's a difference. You might treat them similarly. What's the most common allergic contact dermatitis? Nickel. What do you think is the second most common? Poison ivy. Right. But you can have a contact dermatitis that's a diaper dermatitis just from the moisture. That is a contact dermatitis, not an allergic reaction. Alrighty. Okay. We're rolling. Urticaria and angioedema, something that itches. Itch, itch, itch. Angioedema is the one that needs, you need to be ready to intubate them. Emergency 911 kind of stuff. Epinephrine. Urticaria treated with Benadryl or something that for itchy. This is the one that has the hives or the wheals. It's a problem in the dermis or the subcutaneous dermal junction. This is where when they get angioedema, usually it swells up lips, genital area, throat, lungs. You have to worry about the swelling. Cutaneous drug eruptions. What causes it? Drugs. So if you see in the vignette, this guy has a thing that pops up, and the only thing really they're talking about that's changed is they just recently started a drug. Don't miss that question. All right? Because just don't miss that question. I need one or two of you to miss that question. All right, or James will be at the test board committee, because I won't be here. All right, erythema multiforme, what does it look like? It's a target lesion, yeah. It's not Lyme disease. I don't teach you about Lyme disease. I think one of the lectures about bugs and bites and stuff talks about Lyme disease, but it's not on this test. It's not on this test. It might be on a subsequent test, but it's not on this test. Stevens-Johnson syndrome. What's the most common reason? What's the most common reason for Stevens-Johnson syndrome drugs? The etiology. Toxic epidermal necrosis, that could be from drugs too. But that, some people think that's a worsening of Stevens-Johnson syndrome, basically on body surface area. When you get toxic epidermal necrosis or Stevens-Johnson's, you can have that Nikolsky sign, you remember that? So you send people that have these blistering Nikolsky sign, you send them to the hospital, get treated in the burn unit. Why do people die? Why do they get sick? Why do people die from this?
Secondary infection.
Yeah, infections, secondary infections. Good job. All right. Erythema nodosum, that's that thing that usually pops up on your anterior tibial shaft. It's a red thing, a little round thing, erythema nodosum. All right, let's see. Huh? You guys need a break? No? Keep going? I haven't seen eyeballs rolling up, but you guys were paying attention to this more than you paid attention to any of my lectures. Y'all are really paying attention to this. All right, acne. What's the first thing you need to determine? Inflammatory, non-inflammatory. Yeah, I like you, Major. I like you. Inflammatory versus non-inflammatory. All right, and that'll tell you a hell of a lot of whether they need an antibiotic or they don't need an antibiotic. What medication treats all types of acne you want to use? A retinoid, except for Accutane, which is, except for really bad acne that you use Accutane for, or isotretinoin, that's a type of retinoid, so it does fit that, but it's not a topical one, it's an oral one, okay? All right, retinoids fit all the different things. If you have, there's different types of acne, mild, moderate, severe, mild comedonic type acne is not inflammatory, they would probably just need a retinoid, they need a face wash. Moderate inflammatory acne, they're gonna need moderate inflammatory acne, they're probably gonna need an oral antibiotic, something like doxycycline, that would probably be the one I would pick, and some topical medication, a retinoid, maybe a topical antibiotic too. And then the severe one would need isotretinoin. There are certain labs that you want to take, male or female, and there's one specific one for females of birth control, or ACG. The two forms of birth control with that. Female acne, female presentation acne usually starts and goes away around what? A menstrual cycle. So what would you try to get them to take if they weren't taking it already? Because it's hormone related, you want to modify their hormones with some oral contraceptives, something like orthotricycline or something like that. So, and that's the way you have to try to talk them into it. Other than them having to, they shouldn't have to be taking doxycycline all month long. Maybe start taking a birth control pill a few days or a week before it pops up, and then it will pop up. All right, perioral dermatitis. What do you treat it with? Perioral dermatitis. It doesn't make sense that you would treat it with this. But which one? Not all antibodies. Not amoxicillin. Not Rocephin. Doxycycline. Dermatologists like doxycycline. We treated other stuff too. I've used other medicines, but for the most part, I like to try to stay with doxycycline. What does it look like, perioral dermatitis? It's perioral, not like seborrheic derm, which is not necessarily perioral, and it spares what? The vermilion borders. It doesn't like go up too close to the lip. All right, milia are small cysts. Or small cysts. Know what they look like if you see one. It's not miliaria. Miliaria is a heat rash. Treat that with moisture, cool compresses, humidified air, so the baby or the person doesn't sweat so much. That's how you get miliaria. Milia for children, very small children, they usually will normally go away. You'll see milia with a lot of times adult females or on their eyes. You can surgically remove those, but I wouldn't worry about it. Just know the difference what they look like. Pseudofolliculitis barbae. What causes it? Does staph cause it?
No, it's the foreign body.
The hair, the foreign body reaction, the hair, correct, causes it. Acne keloid nugae, what causes it? Same thing. Hair problems, usually from getting high and tights, people start getting those little bumps on the back of their neck. That's what nugae, neck. How do you treat it? If it has an infection in it, because those hairs can get infected over time, maybe an oral or topical clindamycin or something, but they're going to have to be surgerized for definitive treatment. Small ones you can punch biopsy out, and large ones you're going to have to surgically excise. That's the treatment, surgical excision. Epidermal inclusion cyst. That's a large milia. Usually started out as an irritated hair follicle that the body didn't like and closed itself up and formed a little capsule of tissue underneath the skin. You don't have to treat these. They're benign. If they don't hurt and the person doesn't want to trade a bump for a scar, you don't got to treat it. But the treatment for it, if the question is, what's the treatment for an EIC? Is excision. It's not pop it and leave it and it comes back. But then it's benign. Anything benign, you don't have to treat. They might like it. All right, pilar cyst, that it looks like an EIC, but normally they always show up in the scalp or the hair. And they're a little harder, sometimes they're a little fixed. Usually there's more than one, just be able to identify it. All right, that's all that. Are you still wanting to go, or you need a break? Drive on, drive on. Psoriasis. 3 different types, chronic, glutate, pustular. Usually a silvery type scale, and if you pick at the scale, you get it bleeding, pinpoint bleeding. It isn't like it's gushing blood out of like a vampire got you or something. It's pinpoint bleeding, all right? It's called Auspitz sign. So if you see in anything for the rest of your life, Auspitz sign, that means psoriasis. Now, have I picked at things that look like psoriasis and they bled a little bit and they weren't psoriasis? Yep, I have. Here's newsflash. You pick at something long enough, it's going to bleed. If you squeeze something hard enough, long enough on the skin, stuff is going to come out. So people like to pick zits, even if they didn't have zits, and they pick at themselves all the time, they will eventually get something to come out of that sebaceous gland. And they'll swear that they got zits. And they've just got to quit picking at it. All right, so I'm just talking test questions now. I'm not talking treatment and all dermatology stuff. All right. If it's greater than 5% body surface area, what would be the treatment for the psoriasis? Immunologic, like Intercept or something like that. Remember that all those big long list of words that I said, just remember the last 3 letters and you'll be able to figure out that that's what it was. If it's less than 10%, you need a topical. Oral steroids, stay away from them with psoriasis, okay? And psoriasis usually needs a gel or something with occlusion to get down through that. So if you don't have occlusion and you want to use like a tar-based type thing or a keratolytic, there's one called Keralac that will thin down the psoriasis that then you could use maybe a cream or a lotion for. Yeah, you can do it. But if you don't have a keratolytic, or if they just don't want to deal with it, what I found usually with men is they don't want to dick around with it. They don't like putting 3 or 4 things on something to get it to work. They just want one big gun thing. That's all I can get them to do. So it depends on your patient, whatever you can get them to do. If you think they're going to be compliant with it. For test purposes, no, less than 5%, greater than 5%, that's what you want. But in the treatment of people, that's whatever somebody would use. All right. There's one in particular that is exacerbated by or is usually preceded by a viral or sore throat or strep throat, a type of psoriasis. Usually it's glutate type psoriasis. Here's a newsflash, any of them can be started by a strep infection if you have psoriasis. If you have psoriasis, almost anything can piss it off and make it pop up. That's why you have that thing called Kevnerization. Remember that word? Kevnerized or Kevnerization, usually if you mess with the skin and psoriasis pops up, well, viruses make psoriasis pop up too. But for test purposes, do a throat culture, treat strep infections for glutate psoriasis. And those small ones can coalesce into plaques. All right, I think we beat that one to death. DERM pops up in certain places. It looks in similar areas as psoriasis, but when you look at it, it's like a yellowy scale and not a silvery scale. It's in sebaceous areas. It's going to kind of be greasy if you touch it. It's going to be in the oily sebaceous areas. What's the initial treatment for seborrheic dermatitis? Ketoconazole. Ketoconazole. Trying to figure out if I should say this or not. I don't want Timmy 100% right answer. What exacerbates it, all right? What exacerbates DERM? Look that up. What exacerbates it? I'm not just going to tell you what it is. Pityriasis rosacea. Pityriasis. Know what it looks like. What's the treatment for pityriasis? Pityriasis. That's the one where you can put out in the sunshine and it'll probably go away over a period of time, over a week or two. So do you need to treat it? You could say UVB is treating it, if you think sunshine's treating it. You don't need a topical steroid unless it's really, really bad case of it, it's itching. So the treatment for pityriasis is reassurance that it'll go away, even though they won't believe you. If you are going to treat it with steroids, you use a mild steroid. Which one has the Herald patch? Yeah, Herald patch. Usually starts out in one area, then has the Christmas tree distribution and all that kind of stuff. Lichen planus. Know the 5 Ps. Remember the other day I told you you didn't have to know it? I looked at something and damn it, you're going to have to know it. Know the 5 Ps of lichen planus. Know some of the physical exam findings if you see a picture of it. That's the one with purple, polygonal, planal, periodic type stuff. Know the 5 Ps. I kind of told you one that's not on there. Might have given the test question away. If you see a picture of it and you see something like Wickham or lichen striae, know that's lichen planus. That might cue you to what it may be. You don't remember the other part? Oh man, this is burning me out. Lichen sclerosis, that's that condition that will, well, it's white, sclerotic tissue, kind of leathery, usually shows up where the sun don't shine, very painful, refer it to somebody who can treat it. Necrobiosis lipoidica, know what it looks like. That's the one that could be associated with all the others. What's it associated? Maybe like 80–95% of them is associated with what? Diabetes. Usually shows up as a lesion on the anterior tibial shaft. All right. Grant, I know you guys are recording this, right? You guys will be listening to it tonight, tomorrow. Granuloma annulare. Know the common locations for it? Dorsum of the hands, dorsum of the feet. Granuloma annulare. Acantha's nigricans. You know that one? Pigment, you know, where's the most common place it pops up? Most common place you'll see it. What's it associated with? Or could be associated with? Diabetes. What do you gotta rule out? Especially in kids? Gastric cancer. Gastric cancer. Yep. Xanthomas, those are a few different types. Xanthelasma, xanthomas. What's it associated with? Hyperlipids, hypertriglycerides. There's some that present around the eyes, xanthelasma, some that usually present as little papules or nodules anywhere, some that present on just on the tendons, some that just present on extensor surfaces. Know which ones they are, okay? Because there's 4 or 5 different kinds. That there will probably be pictures associated with it. Just be able to pick it out. All right. Thyroid disease, hypothyroidism, hyperthyroidism. Know which one has the keratocanthema, the carrot-colored palms of their hands. Know which one, has the Graves-like symptoms, which one, has bronze tinting of the skin, which one has the plumber's nails or the spoon nails, Hyperthyroidism has that. Just know that. Bullous pemphigoid, we just talked about this. Bullous pemphigus, bullous pemphigoid, and dermatitis herpetiformis. Know the initial presentation of pemphigus. What does that normally pop up? The mouth. and then start going everywhere else after a few weeks. They're very friable, which means they burst very easily. It's an intraepidermal thing. So they're gonna rupture easy, they'll be very flaccid. Whereas bullous pemphigoid is gonna be very tense and maybe have the serous or hemorrhagic type blisters. They're all gonna have Nikolsky's sign, but it's gonna be harder to get it with the bullous pemphigoid. And dermatitis herpetiformis, extensor surfaces mainly, burning, itching, grouped things. You get all of these diagnoses with what? A biopsy. Pemphigus is intraepidermal, bullous pemphigoid is intradermal. That's where the separation of the skin is caused. They're autoimmune issues. So IgG would treat all of them except for the dermatiformis, herpetiformis type thing, and that's IgA mediated. They're all treated pretty much the same, and you all refer them to the dermatologist. All right. That's it. That's all of it. That's everything that we did. And I'll take any questions you guys might have. Yes, sir.
Sir, looking at two different conditions here, nummular eczema is like a point-shaped lesions.
Yep.
How would you differentiate that from the granuloma and the
Clinically, how I would differentiate, they usually present in different locations of the body. One itches and one don't. Granuloma annulare is not pruritic. It just usually pops up in the same type of lesion. They look kind of the same, but it's usually on the, now you can have very disseminated, see you asked a question, now I'm gonna torture you. You can have very disseminated granuloma annulare that doesn't just pop up on the dorsum of the hands and the feet. If you have it generalized or disseminated granuloma annulare, you need to think of AIDS. I didn't tell you that because I don't expect you to know that, but you asked, so I would biopsy it, but you need to think if something is usually just in one place and you see it all over the body, you need to think of something going on, or they have immune system problem, and it, just like some of the other conditions that I didn't really stress too much on this review, you need to think of AIDS, or syphilis, or some kind of crazy stuff that's going on that's making it look like not the normal thing that you might think. But yes, that's how it's usually written in the location. Anything else? Again, you can text me, you can email me, I may or may not get it, depending on my computer, but texting me always works, so you can always text me. And then I'll be here for your exam, and I reviewed it last night again, and changed some words, but didn't change anything else, just because they didn't read, some of them didn't read right. And my Grammarly thing pointed out where my grammar was sucked on a couple of questions, so I fixed some of the grammar on it. But I think they should be pretty good for you. Again, I need a few people to text them for the team so that James doesn't show up. So if you think you're batting a 98, A's and A's and A. All right? A's and A's and A. All right. Well, you want to say something too? No? Well, I appreciate everything, and I'll see you guys on Friday.
Speaking of which, I told Chris, they had